Okay, let's start part 3. That's fundus, fluorescein, angiography, and we will discuss about interpretation. Okay, before doing interpretation, let me just go grossly on anatomical consideration. Basically, we are doing fluorescein, fundus, fluorescein, angiography, so we have to consider anatomical consideration that blood retinal barriers, isn't it? So let me go grossly. So anatomical consideration, the major choroidal vessels are impermeable to both bounded and unbounded fluorescein. Okay, major choroid. But at the same time, choriocapillaries, the walls are extremely thin in choriocapillaries, capillaries of choroid, and contains multiple fenestration. That's very important, and through which free molecules passes to Bruce membrane. Up to Bruce membrane, it passes free molecules of fluorescence. Okay, so choriocapillary and Bruce membrane both permeable to free and bound fluorescent molecules. So basically, these two structures are permeable to free and bound fluorescent molecule. Okay, then here we come outer blood retinal barrier. What is outer blood retinal barrier? It's very simple, isn't it? Tight junction between RPE cells that prevents the passage of fluorescent into the retina. Basic thing is this. So what is inner blood retinal barrier? We know it. Tight junction between endothelial cells of retinal blood vessels that prevent passage of fluorescent in the retina. So basically, inner blood retinal barrier and outer blood retinal barrier are basically preventing fluorescence to pass into the retina. Whenever these junctions there is a problem and these junctions are not functioning properly, then we will see what? We will see fluorescence in retina. So fluorescence passes through the choriocapillary, also passes through the Bruce membrane, but here we come outer blood retinal barrier. So encounters with a tight junction of intercellular complex zona occludens of RP and prevent the passes. And disruption of barrier leak both bound and free fluorescent molecules. So basically, disruption of any barriers uh, creates the leakage, isn't it? So that's it. Choriocapillaries are basically fenestrated, but the tight junction of zonula occludens here in RP created the outer blood retinal barrier. At the same time, this is choriocapillary, this is retinal capillary. Choriocapillaries, there is a fenestration. Okay, you can see there. There is a fenestration. Through that fenestration, free fluorescence just exit from the blood vessels. But in retinal capillaries, the endothelial cells are tightly junction, so tightly packed, which is a tightly adhesion with each other. So that's why fluorescence cannot escape from the retinal capillaries. These two things are basically, this is inner blood retinal barrier, this is outer blood retinal barrier. Okay, so outer and inner. Outer region is this zona occludens. So okay, fine, this is the anatomical consideration. So another thing is blood vessels in the retina. So grossly, for FFA interpretation, sensory retina divided into two layers. What is inner vascular half and outer avascular half? I think you know it. So inner vascular half basically from internal limiting membrane to inner nuclear layer. So what is this? Here is the retinal blood vessels are located into two separate panels. This is the picture, two separate panels. One is in nerve fiber layer, another is in a nuclear layer, isn't it? So if the blood vessels are located two separate, the larger retinal artery and veins are located in nerve fiber layer, and retinal capillaries are located in inner nuclear layer. This is retinal capillaries, and it is located in inner nuclear layer, and larger vessels are located in nerve fiber layer, isn't it? Retinal nerve fiber layer. So there are two, and from this outer two pigmented epithelium, there are avascular zones where fluid accumulates if retina becomes edematous, isn't it? The outer avascular half is from outer plexiform layer to retinal pigmented layer. If retina becomes edematous, then it is the layer that fluid accumulates, causes cystoid space. So this outer avascular half where cystoid space is formed, because this is a vascular zone of retina. Okay, fine. So I have already explained this picture. So let's come to the point, the fluorescence in the foveal region. Basically, foveal region is look like this, isn't it? A little bit darker. Why dark appearance is there? First, avascularity, definitely foveal avascular zone. If there is no vessels, then there is no fluorescence. and the blockage of choroidal fluorescein because of increased amount of xanthophyll pigment and melanin in RP, isn't it? So basically, foveal zone is highly pigmented zone. So see, outside the periphery of retina, even there is no leakage of fluorescein, but man can see fluorescence of the choroidal leakage, choroidal capillary leakage, isn't it? But in case of fovea, there's melanin pigment in RP is high and xanthophyll pigment in foveal region. So that those two pigments hinder the posterior fluorescence too, in a view. Isn't it? Posterior fluorescence means fluorescence in the choriocapillaries, isn't it? Choriocapillaries are fenestrated, we know it. So so basically the retina, if there is nothing, um, like outer blood retinal barrier, inner blood retinal barrier are perfectly okay, then there is no chance of fluorescence to be leaked. But in choriocapillaries there is constantly leakage because choriocapillaries are very very fenestrated. So that's why these choriocapillaries fluorescence is hindered, basically hindered by xanthophyll pigmented fovea and melanin pigmented foveal RP. Okay, that's the point why fovea is dark in FFA. So what normal FFA look like? What normal angiograph? So basically passive filling of choroid, we have discussed about it. Retinal blood vessels filling, dark area in the foveal avascular zone, but there is no hyperfluorescence or hypofluorescence. Okay, that's very important because it's not the hyperfluorescence and hypofluorescence that is important, and that's not in normal case. At the end of the transit phase, fluorescent dye remains in the choroid and sclera due to the leakage from the choroidal vessels. So basically, choroidal vessels are leaky. At the end of the transit phase, so fluorescence remain in the choroid and sclera. And a small amount of fluorescein also remains in the optic nerve head and the retinal blood vessels, but there is no leakage. What do we call a small amount of optic nerve head? We have already discussed about it. Optic nerve head and sclera, a small amount of fluorescence is remain. Okay, that's late fluorescence. In late stage, that two things are normal, isn't it? Any additional fluorescence in eye should be regarded as pathology. So that's very important. Any fluorescence, additional fluorescence in late phase should be regarded as pathological. Okay. Okay. So small fluorescence leakage or any additional fluorescence should be regarded as pathological. Let's move forward. So basically means this. This is foveal avascular zone, and you can see here, isn't it? So patchy feeling definitely there. So this is very normal. So if something like that. So stepwise approach to FFA. What is the stepwise approach to FFA? The fluorescent angiography should be interpreted systematically to optimize the diagnosis accuracy, basically. Indicate whether image is right or left both eyes have taken first. So comment on the red free image first. First means that reference images. Then indicate any delay of feeling as well as hypo or hyperfluorescence. That's very important. I'll show you that. Basically ladder, and indicate any characteristic features such as smoke stack or leaky feeling pattern. That's very very important. What is smoke pattern, what is stack pattern or leaky feeling pattern? Indicate any evolution through the course of angiogram in the area or intensity of the fluorescence. So it's very important if throughout the course is there anything that's intensity is growing on, or so it's very important. So this is the interpretation flow, fluorescent interpretation flow chart. See, normal is normal. We have discussed about the normal. Okay, what we think is autofluorescence and pseudofluorescence. We have talked about it, isn't it? So there definitely, if it is not optic nerve head or not sclera, then autofluorescence and pseudofluorescence should be taken into account. They're normal. Then abnormal means there are two patterns. See, two patterns means hyperfluorescence and hypofluorescence. What do you mean by hyperfluorescence? Definitely, the name itself calling that if there is a too much of fluorescence, isn't it? Hyperfluorescence. So we cannot see fluorescence. For example, where we cannot see fluorescence in phobia, isn't it? That's what we have discussed about already. So hyperfluorescence means fluorescence seen where it should not be seen, or fluorescence seen too much where it should not be seen. And hyperfluorescence means fluorescence is not seen where it should be seen, isn't it? Fluorescence is blocked or non-filling. Basically, hyperfluorescence, where a lot of fluorescence is there, like this can be due to the leakage. What do you mean by leakage? Isn't it? It means simply mean leakage means leakage. The outer blood retinal barrier or inner blood retinal barrier is basically break. And pooling means one particular area there is a pooling of the fluorescence, staining of the fluorescence, particular structure is stained by the fluorescence. Or window defect. Window is very fascinating defect, which means basically there is something that is hiding behind, but now this hiding thing is open, like window is over, a black glassed window now open. What that black glass in our retina is RP, isn't? We'll definitely talk about window defect. In hypofluorescence means there is we we're supposed to see some fluorescence, but it is blocked. So that's one is block defect, another is non-feeling defect. Okay, something is hindering blood vessels actually blocked somewhere and it's not feeling there, something like that. So these are the gross thing, and definitely there is autofluorescence. So we are going to discuss about, we have already discussed about normal. Okay, so note, hyperfluorescence and hypofluorescence can alternate in the same location. It's very important, especially in case of inflammatory disorder. First, hyperfluorescence due to retinal edema, and later hyperfluorescence due to increased vascular permeability is always there in case of edematous thing. So in edematous there is hyperfluorescence first, and later in this stage you see hyperfluorescence because of the vascular permeability. So it can be there. It's not like you don't see when there is hyperfluorescence and there hyperfluorescence. The both are very different thing. No, it can be occur in the same place. So hyperfluorescence, we have discussed this, see, in every phases, like pre-injection phase, like autofluorescence and pseudofluorescence. And what are the basically things that in optic nerve head drusen you will see autofluorescence. In astrocytic hematoma you can see autofluorescence. At the same time, pseudofluorescence is poorly matched filter. It's very important. The filter should be very good. You know the filter, we have talked about it, that whenever from white light the only blue light is passing, and from the retina it comes to yellow filter. So if that filter is poor, then you will see pseudofluorescence. It's very important. Autofluorescence and early vascular problem. So hyperfluorescence is retinal abnormality and choroidal abnormality. First go to retinal abnormality. Retinal abnormality, like early hyperfluorescence, like toxicity and dilation, anastomosis, neovascularization, aneurysm, telangiectasias, and tumor vessels. You'll see early vascular hyperfluorescence. And in choroidal case, see PE window defect. What do you mean by PE window defect? It's like pigmented epithelium window defect. It's like window means if pigmented epithelium is not there, RB is not there, then you will see directly. In case of atrophy and congenital reduction case, you will see directly fluorescence of choroid. And then another abnormal basis like subretinal neovascularization, inflammation or tumor basis, you will say definitely early feeling of hyperfluorescence. Okay, so late leak or extravascular problems. So what are the late leaks? Like vitreous, if there is a new vascularization due to many things, okay, inflammations or tumors. Or in case of discs, same. In case of retina, cystoid edema or non-cystoid edema, this they come at late. Basically, edema it comes late, basically. And choroidal pooling and staining. These are things that you see hyperfluorescence. Okay, autofluorescence, we have discussed the emission of a fluorescent light in the absence of fluorescence. It's called autofluorescence. So, optic nerve head drusen, astrocytic hematoma, and myelinated nerve fiber. These are the things we will show autofluorescence. See, the optic disc drusen. If there is no fluorescence, without this optic disc drusen will fluorescent. And astrocytic hematoma is also so autofluorescence property. These two diseases. Pseudofluorescence occurs in the non-fluorescence light passes through the entire filter system. Basically means the blue reflected light passes through the green filter and filter pseudofluorescence occur. Basically means what if green filter passes the blue light. What first we send blue light after hitting the retina, the green light is coming. But yes, there is some blue light also. So the filter of green filter has the work to hinder the blue light, isn't it? If it cannot do that, then pseudofluorescence high chance. What are the defect that pseudofluorescence does? Is it first does decrease in contrast as well as resolution of the image, and avoid the pseudofluorescence filters combination to be sure and no significant overlap existence. So it's very important. No significant overlap means blue filter works purely for shorter wavelength and the green filter works purely for longer wavelengths, and there is no mismatch between them. So it's very important that filter must be uh, very clean. So that's why this is the recommendation. Over the time filters alter the range of light transmission, so should be changed in certain time. Author recommends 5 years time to change filter. You have to maintain your filter in photographic filter or whatever FF filter. So let's discuss about window defect. I have already told window means something is hindering it. Now you open it and then you see the fluorescence beneath the window. So what is window for here? Is RP. RP is a dark pigmentation. Whenever focal atrophy of RP, then unmasking of normal background of choroidal fluorescence, because choroidal capillaries are basically fenestrated and there is plenty of fluorescence, isn't it? So that's why characterized by the early hyperfluorescence which increase in intensity and then fade without changing the shape of the size. That's very characteristics of window defect, and you commonly see window defect in inflammation of RP, atrophy of RP, and druseness. So these are the three things conditions you'll see window defect clearly. See, this is the basically means the RP atrophy, and then you'll see in case of druseness clearly hyperfluorescence, isn't it? Even in the slightly later stage. So that's what I want to discuss. So uh, what are the extravascular leak? What do you mean extravascular leak? So pooling and the staining in the choroid and cystoid edema and non-cystoid edema in retina and neovascularization, inflammation and tumor vessels in the vitreous is all thing extravascular leaks. So basically means see in this cystoid macular edema, can you see this? It's very simple. So pooling means accumulation of dye in a closed space. So early hyperfluorescence subretinal space, which is common example is CSR, central serous retinopathy, isn't it? So increase in size and intensity. So early hyperfluorescence RP space, sub RP space, you know it. Pigmented epithelial defect, isn't it? Increase in intensity only, not size. But in case of CSR, there is increase in size and intensity both after pooling. But in case of PED, the size remains constant, but intensity increases. So basically, PED means RP rupture, isn't it? So pooling of the dye in PED, it's like clear circular space and intensity increases with the time. But in case of CSR, subretinal space, even size increases. Even what do you call it? Smokestack pattern is in I think CSR. I think so. Yeah. I think that's it's smokestack pattern. Basically, this is the area where fluid accumulates, isn't it? So CSR increase the size and the intensity. Can you see? Just this is red. Just see from here, 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 here. Now, can you see this small uh, point? And this is small point getting larger and larger, isn't it? So that's what I have called. It's called. I think it's called smokestack pattern. I think so. So can you see neovascularization and the neovascularization? See in FFA. Can you check neovascularization elsewhere? Then in FFA, it's clear neovascularization. So staining means accumulation of fluorescein within the tissue due to the prolonged dye retention and minimum hyperfluorescence in early and mid phase, which increase in the late phase. So basically can be seen in normal as well as pathological tissue altered. Staining means, so basically staining is non-cystoid macular edema and prevascular staining. Subretinal is drusen, scleral, lamellar, cribrosa and scars. You can see staining. So drusens, can you see? Commonly, it's very easy. Late hypertension along the edge of geographic scar. Can you see? This is a scar, geographic scar. Easily seen, isn't it? Easily seen. Focal exudative means this areas. So basically, can you see this area clearly? Yes. Optic disc swelling. Basically, this is the swelling of optic disc. Can you see this fluorescence pattern? Isn't it? Yes. It's very simple. So hypofluorescence means you hinder the fluorescence, reduce or absence of the fluorescence. The two causes I have already on block of the fluorescence or vascular filling defect. So basically, blocked of the fluorescence means what? The optical instrument masking the normal density of fluorescence. Anything optical obstruct. So that causes the lesion of the anterior retina. What is the reason of the anterior retina? Vitreous opacity, preretinal hemorrhage that blocks, intraretinal hemorrhage or hard exudates that blocks. So basically, density of arc increase, congenital hypertrophy, or choroidal lesion, any nevus in the choroid that could cause block of fluorescence. Basically means this. In this picture, can you see this blocks fluorescence, isn't it? Hyper RP getting larger. So this is vitreous hemorrhage. Can you see this blocked, isn't it? Fluorescence. So this is blood at this place, isn't it? Can you see in retinal? So basically, it blocks even choroidal choroidal fluorescence. See this leakage of blood. Can you see this completely blockage of posterior fluorescence? And the filling defect means it's very common. If filling defect means the avascular occlusion, means choroidal circulation or the retinal circulation is occlude. Basically, inadequate profusion of tissue. So basically, loss of vascular bed or severe myopic degeneration, called emboli or arteriosclerosis. Basically means it's blocked, isn't it? See, this is the area where it blocked. Now you can see there is no blood passes from there, and this area is completely black, isn't it? The same thing is going on here. So basically, what is the limitations of FFA? It does not permit to study the choroidal circulation. It's very important. Okay, so it does not permit the study of choroidal circulation. So why? Because melanin in RP, first is RP hinders the study of choroid. Second is low molecular weight of fluorescein, which definitely choroidal capillaries diffuse. That's why to overcome them, we indocyanine green uh, fluorescein, indocyanine green angiography, isn't it? So I will discuss in next video about it. And more adverse reaction. Uh, yes, fluorescein definitely had an adverse reaction, and inability to obtain angiography in patients with excessive hemoglobin or serum protein, and these are the others complications. But in choroidal study, I'll just talk about 1 to 2 slides in next video about difference between FFA and ICC. So that's there. I think that's it for today. We will discuss on fourth video of FFA slowly. I hope that it helps a little bit, and these are my references. Okay, fine. Bis dann, tschüss.